side. Okay, it becomes a short stretch bandage like that. We use short stretch bandages for lymphedema. But the middle of this one's better, so we're going to keep using this one. All right. There are two ways, and the reason we're going to talk about this is where I talked to you about patients who had skin grafts, patients that were below the knee, they burned, we didn't walk them. They were a partial thickness injury, okay? But if they're a full thickness injury, you walk them. Well, if I skin graft that area, okay, it's full thickness injury, we now skin graft it, we wait our 3 days, they take it down, hey, it looks really good. Can I walk them yet? The answer is no, not yet. It's just barely sitting there. So somewhere about 5 to 7 days, you kind of look at it and say, yeah, the skin looks like it's there, it looks like it's not going anywhere, it looks pretty healthy, let's try. But it needs some kind of counter pressure because gravity remains in effect, so as soon as they put that leg below the level of their heart, the blood pressure is going to increase. It's going to break some of the new capillaries no matter what, and if we break enough of them, that skin graft will actually die and fall off. You don't want to be the person who did that. Nobody's happy. Okay, so you need to use some kind of counter pressure, and we actually developed a dangling protocol. The time frame has gotten shorter. It used to be 7 days. It went to 6 days. We got 5 days. Sometimes I can even do people at 3 days, but not usually. If they're a small burn, say maybe she just, got the tailpipe of a motorcycle. Okay, so she's got a burn on her leg, and they skin grafted it. We might even put her in some kind of compression like an Una boot or a Coban 2 or a 4-layer compression wrap or something like that and let her go home. But you need that counter pressure. So anyway, what we did with the skin grafts was we figured out that if you check the patient frequently, that you could determine whether they were going to lose their graft or not lose their graft. So what we do is we take their bandages off, look at the graft. Make note of what's purple, what's pink, what's red, what's not healed, what's healed, and look at it and see how it looks. We decide the skin graft looks pretty good, then we're going to start to dangle them. So you still need to put some kind of a barrier on there between this and that. Okay? So if they've got adaptic on, we may put their adaptic back on, and maybe a quick Curlex over top of it, because I'm going to want to check this every minute, and I have to get back to that to be able to see the skin. So you're going to put as very little bandage as you can on it. Okay? So I look at it, I think it's okay, I put the little things so nothing sticks on there, and then you start down here by their metatarsal heads. All right? When people bend their ankle up and down, because it's elastic, it will migrate this way. So you need to make sure you don't start here because it'll end up here. Okay? You want to really start down by their metatarsal heads. You should also always, when you ace wrap with the roll on top. You have much more control. We got any left-handers in here? Okay, not here. We're good, we're good. All right, your right hand's your main hand, your left hand's your other hand. It's your guide hand. If you wrap like this, it's very hard to control the tension. Always roll your ace wrap before you do it. Okay, working with spaghetti is always a disaster. You don't get enough tension, it's very uneven. So you start with the roll on top, you anchor this. You just come around once and you anchor it. Now you get two choices. You can do a spiral wrap or you can do a figure 8 wrap. You guys have learned both of those, correct? Somewhere along the way? Okay, sort of, kind of. A spiral wrap is not very even compression. Works out okay if you just got a little swelling in your ankle or something, but doesn't work out real well if you want consistent, even compression as it goes. So you anchor the foot, you come back around, bend your toes towards you, dorsiflex slightly, there you go. You want them in neutral, okay? I find it works best then to come around, get the point of their heel, the apex of their heel. So you've got that covered, because that's always the hard spot. Come back around, now our entire foot's covered, okay? And now we're just gonna spiral it up. And you're gonna, what? No, she's mumbling. Did I miss something? No, real smooth. Okay. You're going to overlap about half the width of the bandage. And if you look, you can see that where it was underneath, the other one is underneath. So mostly you're going to wrap at a little bit of an angle upward and probably about 50% of the tension. The patient will tell you, it's too tight, it's too tight. Okay, if this is the first time you've done it, maybe it is. But you don't want it too loose. You need that counter pressure and you need to convince them that they need it. All my compression wraps, the first time I put them on a patient, they always tell you, it's awful, it's terrible. I can't live with this. Yeah, you can go home. With them, as their swelling gets better, the wrap will get looser. On these patients, we just want to know that it's on there with the counter pressure. So then, thank you, but I'm okay. Then I'd have them scoot forward, just gently, or just swing your foot that way. And dangle her foot. Okay, she would dangle her leg. We would count, literally, for a minute, 1 minute. At 1 minute, if she's not complaining, we're good. So put your foot back up, and we would quick unroll it, and look at the graph. Okay? Pain, if she complained of severe pain, we would stop right there. She'd go back to her room, we're done. If I look at it and it's bleeding, you're done. We're not walking today. If it turned really purple, we're not walking today. If it looks about the same, we're good. That tells us that the graft is well adhered, that it's healthy, and that it will tolerate more compression. Because when I stand them on this, it's even more pressure. So then you have to stop and roll your waistband back up.
So when you do get them standing initially, do you do the check at that point as well?
Usually if they make it to 5 minutes, they should be good to go. The graft is okay. If I can dangle them for 5 minutes, then they're good to go. If you were going to do this the first couple of times, I would do every minute, and that's when we started. I've done it enough times that I understand what the graft is supposed to look like, so we'll go to 2 or 3 minutes the second time. But pain, purple, bleeding, anything abnormal, wait till tomorrow. It's okay. I'd rather they kept the graft, and we'll catch up on the walking later. But if they tolerate it, let's get them up, let's get them moving. It's better for everything. The other kind of wrap you can do, and I generally do, is a figure 8 wrap. Starts the same. Start down by their metatarsal heads, get them to hold their foot neutral, anchor it, come up, get the apex of their heel, come down, go around. Now you're going to go up a little. This time I'm going to come down a little. I'm going to come up, I'm going to come down. And we're going to still overlap about halfway. Up, down, and up. That would feel any different to you? Some people can tell, some people can't. It's a more even pressure up and down. You want more pressure distally, less pressure proximally. Doesn't mean you necessarily change the tension, it's just that's what you're looking for. Anyway, dangle her again for 2 minutes. 2 minutes she looks good. We'll do it again for 3. If 3 looks good, we'll do it again for 4. 4 looks good, we'll do it again. 5, she looks great. We're good. Then we tell her, now we stop. Now we walk.
You're checking to see if she's having pain. Dependent
While she's in the
position?
dependent position.
Okay.
And tingling and burning don't count. Because as gravity pulls, that blood pressure is going to increase, and they're going to get that sensation. They're going to get that feeling of blood flowing. They're going to tell you it's going thump, 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 thump. And it is, because blood pressure in that foot is increased. You can get them to wiggle their toes, you can bend their ankle up and down. If they kind of just play some burning stuff, you just tell them bend your ankles up and down. It usually changes the blood flow and the circulation just a little bit, and it helps. Yep.
Out of the size of the ASAP, so you could use like 3 inch all the way to 4 inch.
A leg you should be using 4 inch, and you may take 2. If I needed to wrap them all the way up to the groin, I'd use probably 1 or 2 4 inch and a 6 inch. I would not use a 6 inch down here on their foot. You don't get enough control, it doesn't work out very well, unless you've got somebody who's got a really big leg and a really big foot. Occasionally you do, but nobody in this room qualifies. So yeah, 4 inch ace wrap. And if you're doing a figure 8, you probably need 2. You don't want, the tendency is to get down here and start doing this. And what happens is it's a tourniquet. Your lymph system, back to my silly lymph system, is very close to the surface of your skin, okay? So if I put a tourniquet on it, we've slowed that way the heck down, and then I can still cut off their blood supply for their arteries. Their foot's gonna go to sleep. They're not gonna like you. They're gonna swell below there, and you're just gonna have a mess, okay? So it takes a little practice.
So once you get done with your fit observation, so it's been 5 minutes, you observe after that time, you take off the wrap, you look at the site, then do you wrap them up again and get them off?
Yep, just wrap them up, and you stand them up, because you still need that counter pressure.
You still need the counter pressure, so you get them up and you just start walking like that. Now after that, you just take it off and or you have them go
Once
back.
I have them elevated again, they can take it off.
Okay, that's
If they've been a great patient, they've had a relatively small burn, and they did great with me, and they're gonna walk with nursing to the bathroom later, I just leave them wrapped. Most people do not tolerate an ACE wrap while they sleep. They don't tolerate They're vascular compression garments, will tolerate the firm ones when I talk about them, but the vascular ones, because they have elasticity to them, and when I put you in bed, what happens to the blood pressure in your leg? It decreases, but that elasticity doesn't, that counter pressure doesn't, so it still continues to tighten and people become uncomfortable. They claim you can actually cut their circulation off. All right, pair up with each other. I have 2 3 inches and 3 4 inches, so. Get those two.